Please welcome Corinne Pinter to the stage.
Hi, good morning, everyone. Oh, this is good. Good morning. I see you all in the back. I can actually see you all back there today. It's been a struggle with these lights. Well, good morning, and thank you guys for joining us today. I'm delighted to see how many of you are here this morning, actually. It's hard. It's fine. Today, we actually have such a great speaker. I'm really excited. Got to hear her do the run-through, and you guys are in for it, so get ready. Open your listening ears, your thinking caps, all those things. So today we have a wonderful opportunity to learn from a true expert and trailblazer in the field of pain management, Dr. Cara Hoffart. Dr. Hoffart is a renowned pediatric rheumatologist and medical director of the Rehabilitation for Amplified Pain Syndromes, or RAPS program, at Children's Mercy in Kansas City. Her impressive resume includes completing her pediatric residency at Children's Mercy and rheumatology fellowship at the Children's Hospital of Philadelphia. In 2012, Dr. Hoffart returned to Children's Mercy with a clear mission to develop an interdisciplinary pain rehabilitation program for adolescents struggling with chronic pain. The innovative program, the Rehabilitation for Amplified Pain Syndromes, or RAPS program, has become a beacon of hope for those debilitated by persistent pain in the region. Through a functional approach, the program empowers children with chronic pain to break free from the constraints of their condition. Likewise, Dr. Hoffart's dedication to finding effective solutions and her commitment to personalized care has profoundly impacted the lives of countless young patients and their families. We are honored to have her here today to share her expertise, experiences, and innovative approach to helping children with chronic pain find renewed hope and reclaim their lives. Please note on your table, there will be time for questions at the end of presentation, and on your table there's cards again, so please jot down any questions, and a volunteer or staff member will pick them up during the program. With that, please join me in welcoming to the stage Dr. Hoffart.
Good morning. Thank you so much for having me. I appreciate the invitation from the Arthritis Foundation. And while I often get to talk about pain with my colleagues, I most enjoy having the opportunity to talk with the people we enjoy interacting with the most, and that's our families and our patients. So I have nothing to disclose. So we have several objectives today. So hopefully when you leave here, you'll understand the 3 types of pain that can impact your child and really understand the biopsychosocial model, which is a big word, and we'll get into that later, behind chronic pain. We'll have an opportunity to discuss some pain prevention, but more of that will be available, I think, at the round table after this. And then to describe a multidisciplinary treatment approach for chronic pain conditions. So a few disclaimers. My practice is with young people, but the information that I'll provide today really applies to most everybody, and also in the adult population. This talk is definitely not focused on the treatment of arthritis or necessarily always pain with active arthritis, rather about the pain to some degree in the presence, but also in the absence of disease activity and inflammation. And just my biggest disclaimers, in all cases, obviously thorough medical evaluations are needed to ensure that nothing is being missed or there aren't other conditions that need to be addressed. So to work closely with your healthcare team. And then please, please, please always discuss the use of all prescription medications, over-the-counter medications, and any non-pharm therapies with your child's doctor before you would pursue anything. So I already got a very stellar, kind introduction, but briefly about me. So as you said, I am a rheumatologist, a pediatric rheumatologist at Children's Mercy in Kansas City. So I spend some time on the rheumatology team, taking care of children with arthritis and lupus and other rheumatic diseases. But as stated, I also went to Children's Mercy with the intent to create a multidisciplinary pain program. So I have a pain clinic that's right across the hall from my rheumatology clinic. So I see kids who have underlying rheumatic disease who develop chronic pain, as well as kids who are generally healthy who develop chronic pain. And so we have a clinic where we see these patients, and then kids who need additional support and intensive therapies. We've developed an intensive pain rehabilitation program, which we won't really have time to talk about today, but certainly I'm happy to chat more after this about what that program entails. And then I've been very fortunate to have, our whole team has a very close relationship with our local Arthritis Foundation chapter, and I was a board member at the Heartland chapter for several years, and it's just so great to see the opportunities and avenues that we're able to collaborate together to provide for our families. So what is pain? That's a really big question, and this is sort of a trick question. So your options are, is it a warning signal? Alert, alert. Is your body telling you something is wrong? An unpleasant sensory and emotional experience associated with actual or potential tissue damage? Is it a matter of behavior? Is it unpleasant feeling that makes us do something different? So changing that behavior. Or all of the above. You may have guessed it is all of the above. So pain is incredibly complicated. In summary, it is a warning signal and meant to protect us so you don't keep your hand on a hot stove, so it's a protective mechanism. It's unpleasant, obviously, and it encourages us to change our behavior in the moment from what you're doing. Pain can be ignored or interpreted differently from person to person, even within families and across different communities. So pain is a very individualized experience. So I wanted to start with a case that I recently saw in my pain clinic, and then we'll revisit this case at the end, but I think it kind of sets the stage for some of the types of patients that I run across in my clinic. This was a patient referred to me from out of state who was followed by her local pediatric rheumatologist. She had been diagnosed with juvenile arthritis about 3 years ago. At that initial presentation, she had joint swelling and pain in numerous joints. She was put on several different immunomodulators to treat her arthritis, and despite swelling seeming to get better, her pain persisted, so they kind of kept trying different medications to see if they could better treat her disease. But she seemed to be failing all of her medications, and her pain had gotten so bad that she was missing school for pain, and at times she was using a cane or a walker, and sometimes even a wheelchair for mobility. And over time, not only did she have joint pain, but she developed abdominal pain, nausea, headaches, and extreme fatigue. So that's someone who's typical and that comes to my pain clinic. So first, I kind of wanted to spend some time talking about what pain should do and what normal is for pain and when we should have pain. So for example, when you have active arthritis or inflammation in your joint where your immune system is overactive and attacking that joint, when you have true active inflammatory arthritis, typically there's pain, but not always. Actually, about 15% of kids, up to 20%, may not even experience pain when they have arthritis. So pain is not always a great indicator of disease activity. So then we have to lean on presence of swelling, warmth at the joint, restricted motion of the joint, so it's not moving very well, other symptoms like morning stiffness. So those are the physical exam findings that we really rely on to help us diagnose arthritis. Normal pain transition is the peripheral nerves, meaning in your arms or your legs, might detect change in pressure or temperature or have these chemical changes that are triggered by something like arthritis with inflammation. That pain signaling starts in the periphery and then is sent up your spinal cord and then into your brain where you interpret the pain signal. That interpretation is then modulated by your past history, by stress, by what pain means to you, what your expectations are for what's going to happen with your pain. So this is nothing you have to memorize, but that idea of the pain starting in an extremity, going up the spinal cord to your brain. And there's not just one center of your brain that interprets pain signals. When you have pain, it goes to multiple parts of your brain. So you can get parts where you have no control over, like in your cerebellum, where you can actually get autonomic symptoms, so things like lightheadedness, dizziness, swelling, temperature sensitivities. You can get gut responses where your pain transmits, so you can see abdominal pain or nausea. And then there are emotional parts of your brain, like the amygdala and the thalamus, that also get pain signals. And so because those emotional parts get pain interpretation as well, then pain is really influenced by feelings and emotions and your previous experiences and memories. And then your pain is also processed in the part of your brain that does the thinking and the reasoning, and that helps you cause more attention to pain. And so really looking at your pain and thinking about your pain and deciding what you're going to do about your pain. And while all of this is happening with your pain signaling, at the same time, other parts of your brain and your spinal cord are working to decrease the pain response in general. So then you want to dampen that pain response so it doesn't keep going up, up, up. Long story short, multiple mechanisms impact the way that you experience pain and the way that your brain processes pain, and it's not very straightforward and it's very layered. So what's supposed to happen when you have arthritis, obviously parts of your immune system are overactive, and now we have, over the last several years, developed all of these amazing medications that target all of these different factors of the immune system. So you certainly don't have to memorize this slide, but it's just to indicate we have so many medications now that target different parts of the immune system to decrease that inflammatory response. And with that decrease in inflammation, or you take away the trigger of pain, pain should go away. It shouldn't remain. That's what we expect. But sometimes nerves don't get the memo. They don't understand what they're supposed to do. So even if you take away the trigger, your pain can actually continue to fire. Those nerves don't necessarily stop. There's a short circuit in the process that causes those nerves to get on a loop of pain. And once your nerves start to fire, the easier they fire, the bigger they fire, the stronger they fire. So now things that should maybe hurt this much end up hurting this much. So it takes that pain signaling and amplifies it significantly. This can certainly happen in kids who have underlying chronic disease that cause pain. It's kind of a perfect setup, and it's not surprising to see that. But this can also happen in kids who are completely healthy individuals who don't have inflammatory pain, and maybe they had an initial trigger with an injury, or an illness, or some other, or some people just wake up with pain one day, honestly. So there are 3 types of pain. I think it's important to know that. So one is this nociceptive pain, which basically is a fancy word for injury-related pain. So if you put your hand on a hot stove or you sit on a thumbtack, you're supposed to have that pain signal so you jump off the thumbtack and don't keep harming yourself. And then there's inflammatory pain, which goes along with the arthritis that we've already talked about. That inflammatory pain is there to help you heal, so that way you don't go run a marathon when you have a big swollen knee. So that pain is there to help you rest and to let the tissues heal. So pain is supposed to be a good thing. It's supposed to help us modulate our activity and know what to do, when to seek help, see a doctor, take medicine. But then sometimes pain does get dysfunctional, like we just talked about, where the nerves don't get the memo. And that pain becomes maladaptive, and it's actually not very helpful, and it's sending you signals that you don't need and can really cause a lot of confusion to your brain and your body. There are a lot of terms used to describe this type of pain, so you'll kind of hear me use some of these terms a little interchangeably. And I think that's one thing that makes chronic pain confusing. In the pain community, we can't even agree on what to call it. So there's certainly the term central sensitization syndrome, which basically means this centralized process in your nervous system that becomes abnormal. The new term that people really like to use is nociplastic pain. So they're trying to get fancier, I guess. And then I often use this term amplified pain syndrome because I think that is a nice umbrella, kind of a catch-all term, because there are a lot of other pain conditions that fall within that umbrella as well. Within this, within that umbrella would also be included, like if you've heard the term juvenile fibromyalgia, and some other terms like that. So for example, how do you get to amplified pain? So for some patients, they might have an injury or an illness or inflammation that can lead to pain. which can then decrease their mobility and essentially, ultimately over time, even lead to loss of fitness, which then the pain itself and the decrease in activity can cause more sleep disturbance. When you have sleep disturbance, then you have an increase in pain and fatigue. When you have increased pain, your sleep gets worse. Then all of those factors can impact your ability to attend school, to play in your sports, do activities with friends and family, and can really start to impact your life and who you are. And so then a lot of my patients will start to lose their social contacts, and it becomes very isolating. And that really leads to amplified pain syndrome. Over time, they lose confidence in their body. It starts to impact self-esteem. It starts to impact their mood. Because of pain and no one can figure out what it is, they're told to just be still and immobilize and don't do that anymore, which can then further just loop around and feed this whole cycle. So as I said, with chronic pain, the nerves keep firing even if they're not supposed to. And maybe what starts out as pain in one spot, like your knee, over time can spread to other areas of the body because nearby nerves also become responsive to that chronic pain signaling. And I kind of look at it as small electrical explosions that is a chain reaction. And so over time, you could get pain at any spot in your body because you have nerves in every inch of your body. So that can lead to headaches, chest pain, belly pain, nausea, sensitivity to light, to noise. So all of those things and that hypervigilance can happen because of this nerve sensitivity. And then there's a chemical signaling in the nerves that actually leads to change in your blood vessels. So those are these autonomic symptoms that happen. That can be swelling that comes and goes. You could see color change with pain, where your skin could get bright red with pain. It can turn blue with pain. You might have temperature change to your skin with pain, also with arthritis. You might hear some overlap, which makes it confusing. And so that temperature change can be hot or cold, or you can feel hot or cold. You might have more temperature sensitivity, have more hot flashes, or I'll have patients wearing big coats when it's 90 degrees out. Also things like dizziness, lightheadedness, feeling like you're gonna pass out, actually passing out, are all symptoms that can be related to how the blood vessels interact with these pain nerves. And then the processing in that spinal cord increases that signal intensity, and you lose the ability to dampen the pain response. So we talked about before with normal pain, while this pain is increasing, you have this other side of the story that's working to dampen that pain response. Well, with this condition, you start to lose that ability. And then your brain keeps pain going by now paying more attention to it, checking in on it, monitoring it, and then starting to change your behaviors because of it. And so those pain signals become very practiced, and the brain becomes overprotective. So when you have pain due to inflammation or an injury, it's supposed to be protective. But when you have this abnormal dysfunctional pain, you don't want it to be overprotective, but it starts to just really pay attention and do that. And then just your history with pain and other things and memory can set the stage for how your brain interprets that pain signal. What's really interesting is that research over the last several years has uncovered through laboratory models and research that when patients with arthritis and rheumatoid arthritis specifically, so looking at adults a little bit more, when their inflammation is fully resolved, they are finding that pain can persist for weeks to months, even though there's no active inflammation. And so what we're starting to find is that nociplastic or amplified pain changes, both peripherally and centrally in the nervous system, can contribute to this ongoing pain more than we previously recognized. And that pain in kids with arthritis can actually be a greater contributor to disability than to the disease progression itself. So it's really something worth understanding and knowing how to approach. So looking at this inflammatory pain versus this nociplastic amplified pain, it's really important, obviously, to treat active inflammation. You want to make sure that we're removing underlying triggers and making sure that the joint is healthy for a lot of different reasons. So you want to be proactive because what we've also found in research is when you have something like arthritis, it's essentially priming your nerves to be ready to alert to pain faster and bigger. And so that's a priming mechanism, so you want to work to remove that. So that's why you want to work closely with your care team on finding the right medication for your child and adherence to the medication to remove those underlying factors and triggers. And then knowing if it's inflammatory versus this amplified pain response is going to impact how you make decisions about what you're doing with your child's doing for their activity and things like that. So that's important to know and to figure out. And to figure out that sometimes even though something hurts, it doesn't mean it's dangerous. So the effects of chronic pain, I think, are underestimated, but it is thought that 15 to 40% of children will experience chronic or recurrent musculoskeletal pain at some point in their childhood, and this is just in healthy kids. So that is how large the pain issue is in pediatrics. We know that when you are battling chronic pain, it invariably impacts your mood, and it can lead to increased risk of anxiety and depression. We know that when you have chronic pain, that can increase your healthcare utilization, so more testing, more attempts to try to find treatments. And it can negatively impact, as I mentioned before, relationships with peers, with family, with teachers. It can lead to more school absences, which ultimately can also lead to more parental missed days of work. But pain is really described by a very complex biopsychosocial model. And this is true for all forms of pain. No matter the underlying reason for your pain, pain is informed by this model. So whether you have active disease or not, this is true. And so first, pain is informed just by individual history. What's your previous experience with pain? How do you typically respond to something like that? What was the nature of what caused it in the first place? And then there are so many biological mechanisms, some of which we understand, some of which we're still learning. We certainly know there can be genetics of pain. We've started to identify some genes that predispose some people to have pain more easily than others. We know that the immune system is involved in people who have chronic pain, even if they don't have a rheumatic condition. When we look at populations of people with chronic pain, there are cytokines or parts of their immune system that look different from people who don't have pain. The endocrine system's involved, so sleep cycles are involved. There's a lot of biology to the pain. And then there are psychological factors. So whether you already or have a predisposition to anxiety, or if you are kind of a catastrophizer, meaning kind of a worst case scenario thinker, or very forward thinking, just your overall level of stress and coping, and all of those types of factors can impact the way that you deal with having pain. And then there are a lot of social and environmental factors. So how do parents respond when you're experiencing pain as a child? How do your teachers and coaches respond? How do your peers respond? So all of the responses of those people in your life can further impact the way that you respond to your pain as well. So one thing I always think is important is acknowledging the fact that juvenile arthritis in many ways is invisible disease. So is chronic pain conditions. And there's so much overlap across these conditions in that way. And the journey to getting a diagnosis of arthritis or a pain condition can be incredibly long and very frustrating. And it's not unusual to hear that people underwent lots of testing, saw lots of doctors before they finally reached their diagnosis. And so both children with arthritis and pain conditions often feel unheard, invalidated, and often dismissed by their medical providers or other people in their lives while awaiting diagnosis, which is really hard. So I think a major take-home point for me when talking about this is that no matter the source of your child's pain, whether it's arthritis, whether it's overactive nerves, or whether it's both, it's real pain. Pain, and I tell all of my patients, pain is not in your head, because pretty much every patient I have ever met that comes through my pain clinic Someone along the way has made them feel bad about their pain or made them feel that, well, it can't be that bad, all your tests are fine, you must just not want to go to school anymore. And they just start to made to feel like it's not real and it's all in their head. So it's really important to validate this pain. It is real, and I never have to see your pain to know that it exists. So how do you know if it's inflammatory pain or this amplified or nociplastic pain? It's tricky, and we don't expect you to know, and this is where working with your healthcare team is really important. And I think raising these questions with your child's doctors is important. So it's not always easy, and it's not always easy for the rheumatologist even either. And so, but definitely lean on your pediatric rheumatologist and other healthcare team members to help figure this out. We don't expect you to diagnose this by yourself. As I said earlier, pain is not always the best indicator of disease, because you can, with active arthritis, you may have pain, you may have no pain. And then if you have amplified pain on top of your arthritis, you may have tons of pain and no disease. So pain is just not always the best avenue to figure out if disease is active. So we really do have to rely a lot on physical exam findings, so like swelling, the warmth, the decreased range of motion. But noting that sometimes, as I said before, you can have swelling with pain itself, but that type of swelling usually comes and goes, is a lot more sporadic, whereas swelling with arthritis tends to be more persistent and doesn't just come and go as much. You can look at labs, certainly if there's inflammation on the labs, and that's helpful, but a lot of times with arthritis, labs are totally normal. So if you're really still not sure, then the be-all, end-all is imaging. And I have certainly myself had patients where we're just not 100% sure because physical exams aren't perfect. And before we feel we can move forward with the treatment strategy, we've done imaging to really see if there is inflammation there. So X-rays can be a little helpful, but more so the gold standard is things like ultrasound, and certainly MRI is the be-all, end-all. And sometimes we have to do that just to know for sure because it really impacts our treatment plan. So specific characteristics we tend to see with kids who have developed chronic pain conditions on top of arthritis, excuse me. More so, we see these conditions happen in teenagers, so that's the more age, usually like 12 or 13 to 18, but we are seeing these conditions increase more and more in school-age kids as well. A lot of kids with amplified pain develop skin sensitivity, where there's pain to touch or pain to light pressure. They don't like getting hugs because it hurts. The fancy word for that is allodynia, so that's not always present, but in a lot it is. They might start to have other complaints like headaches and fatigue or GI symptoms. They said they might have intermittent swelling. I tend to find that my patients who have chronic pain conditions that have seeped into this have more disability than my patients who have arthritis. My patients with amplified pain tend to have more disability than my patients even with active arthritis. And I'm just clearly speaking in generalities, and there are nuances to that. But I tend to see a lot of disability in my patients with pain syndromes. They're missing school more, they are missing their activities, they are hanging out in their rooms, they become a lot more isolated, and they just are going through therapy after therapy without seeing improvement. And I think the other caveat that's important to just mention is that there's kind of these extremes of inflammatory active disease, and then there's this chronic pain syndrome with nociplastic pain. But then somewhere in the middle, sometimes when you have arthritis, you just have a bad day, or you might have a bad week, and where you just feel more achy and more stiff and maybe more tired. And that can certainly be influenced by weather or temperature changes. It can be influenced by diet. So if you really had a sugar splurge that weekend, you might feel it in your joints more. Certainly changes in activity or poor sleep, all of those factors can impact your immune system and your arthritis and your symptoms. That doesn't necessarily indicate a lot of active disease or enough where you would change treatment, but I think also having some game plans on days where it's just harder. And so we won't explore that a lot here now, but certainly we could talk more about that after this. So I think there's a misconception, especially in the medical community, that, well, now we have a diagnosis, now we're good, right? Let's just move forward, we'll treat this, and everything is fine. But even once arthritis is treated, or chronic pain conditions for that matter, there still can be a lot of stigma with the underlying disease that our kids experience, sometimes more than we realize, because I find most of my teenagers tend to hold on to those feelings and stuff them down. And as I said before, this is invisible disease, which can feel just really frustrating and invalidating. There's also a lot of, you might have noticed it, ageism when it comes to juvenile arthritis. Well, I didn't know kids could get arthritis, which again feels invalidating to our kids and can feel embarrassing to them when people say that. And then they just feel that some people don't get it, and that might be teachers or coaches or peers, and that can actually lead them to try to conceal their diagnosis and not share with people what's actually going on with them and trying to look normal, even though things feel really hard. And all of those different things can really impact pain and daily activity. Which leads me into chronic illness, chronic pain. It's stressful. Even if you are handling it in the best way possible, it's stressful. And to be human is to have stress. You can never get rid of stress. It is there. And so we know that pain alone starts with all of this physiology, with your immune system and nerves and blood vessels and the way that your brain interprets pain signaling and these abnormal responses to pain. But what you cannot ignore is the emotional experience of pain and the emotional experience of dealing with a chronic disease. And so pain alone is an emotional experience where pain increases stress and stress increases pain. And a lot of my teenagers are like, I don't have any stress. But usually in the course of the visit, we can talk about their sports and their grades and their peer groups or their siblings. And like I said, we all have stress somewhere. Even if you don't notice it, it's there. And so pain alone is stressful, which can actually have a big impact on mood. So dealing with pain most every day can increase feelings of anxiety, low mood, sadness, depression, irritability, anger. So you might see mood changes just from this alone. And then pain causes a lot of trouble. It makes it hard to do your activities, do your sports, be at school all day, every day, do things with friends. Then that becomes stressful. And then there's just regular stress of school, grades, friends, pandemics, world peace, things like that that you have no control over, that a lot of our kids are thinking about, that also becomes stressful and can feed your pain cycle. So when we deal with pain, you have to deal with the physical and the physiologic side of pain, but you also have to deal with the emotional and stress side of pain. And so we really work to retrain the nervous system. And the nervous system specifically that's involved when you have chronic pain, it's called the sympathetic nervous system, which is known as your fight or flight nervous system. So that's the one that gets turned on if a tiger is chasing you. And if a tiger is chasing you, your heart starts racing, your palms get sweaty, and hopefully you run really fast from a tiger. But you get a huge stress surge in your body when you're running from a tiger. That's what's happening when you're in pain all the time. And then you also we want to work to increase, so you want to decrease that response, and then you want to increase your parasympathetic nervous system. So when your sympathetic nervous system's up high and your parasympathetic's in the basement, you want to flip those around. And your parasympathetic nervous system is the rest, relax, and digest nervous system. If you're running from a tiger, you are not relaxed, you are not rested, and you are not digesting food because your body doesn't care about that. Hence a lot of GI symptoms that come up when you're in this sympathetic state. And so we want to build that parasympathetic response and treat both the physical and the emotional, no matter what the underlying trigger is. So this is true even if you have active arthritis or other conditions or just chronic pain on its own. So clearly this is a complex biopsychosocial model for pain, which means we need a multidisciplinary treatment approach. There's not just one thing that's going to work on this and fix this. So let's go back to our case that we talked about at the beginning. So our 9-year-old with JIA who'd been on a multitude of medications, needed a lot of help with walking, was missing school for pain, and also had now belly pain, nausea, headaches, and fatigue. Well, when we did more exploring, we also found that she had an MRI recently of her knees and her hips where her arthritis used to be that are now totally normal. So there's no evidence of inflammation or active arthritis, which is good news, but really frustrating because she still has a lot of pain. Her labs are totally normal, but her pain persists. It's constant, severe, and spreading, and really impacting life. So with her, first we just reassured that everything looks great. You don't have evidence of disease activity, but yeah, you still have a lot of pain. And so I always explain with all my patients the science of their pain and what's happening and how all of these different things intertwine. And I validated her pain that it's real. And she was frustrated with that, and she became tearful when I said, this is not in your head, because she certainly had at least heard that or felt that was implied before. And so we talked all about amplified pain for her, and that while she needs all these medications to treat her arthritis and keep her inflammation under control, they may not actually help her pain, and frankly, there aren't many medications that help this type of pain when it's the nerve pain. What we actually know, and there are a lot of medicines out there that people try for nerve pain, and we can certainly talk about those in this next session, but there's actually no evidence that medications for this type of nerve pain significantly improve pain or quality of life for these patients. It's not to say that some medicines can't take the edge off, but they aren't going to fix the problem. So if medicine doesn't work, what do we do? So first, we really talk about pain in the realm of dangerous versus not dangerous. So like I said, pain is supposed to be an alert system to say, don't do that anymore, that's horrible for you, that's really dangerous. But not all pain is dangerous. So because of that, the way we approach pain has to be different. And as I said, when pain is dangerous, then you should rest, you should take it easy, don't do that anymore. But that's not how we do this type of pain. So one, we really work on the overarching idea of pain decision-making. The more you make decisions due to pain and health when pain is big, the more the brain then checks in on your symptoms, which then grows attention to pain, and then it makes your symptoms stick more. So if you start walking for a while and your pain goes up and you're like, oh, how am I doing? Should I quit walking? I wonder if I could go further. I should probably just quit walking. And you decide to quit walking. Now you just gave your nerves a high five and said, good job, guys. Walking is super dangerous. So next time that we walk, let's remember to send that pain signal again to get them to stop walking. On the flip side, if you start walking and your pain goes up, but you feel confident this is your amplified pain, and you decide to go further, now you're teaching your nerves, walking's not dangerous, you're the boss, and it's okay to walk further, and they should be quiet. And eventually your nerves are gonna get bored with this, because they're like, this kid doesn't even listen to me. Like, why am I doing this anymore? And eventually they're gonna stop doing that because you're not paying attention to them. But that's where you have to feel safe in doing that, hence working with your healthcare team to that, on doing that. So overall treatment, assuming there's no active arthritis, and still some of this applies even if you do, one, you really do need that definitive diagnosis and treatment plan. You need to feel comfortable that it's okay to stop looking and it's okay to stop testing, and now it's time to move forward to get better. Because the more you do testing, which sometimes is necessary, but you're bringing your brain's attention back to the symptoms and making your brain focus on it more. Or, oh, now I've tried this, how am I doing? Now we've done this, how am I doing? And so your brain just keeps coming back to that and back to that. So it's really helpful for your child to say, this is what's happening, we know what this is, we know what to do. Do not immobilize to treat pain. So if there's pain in your foot from amplified pain, don't put on a boot, don't do braces, that can actually make it worse. One, that immobilization keeps your body from doing normal functional activity. Two, it draws your brain's attention to it. And in general, we don't immobilize for arthritis either. Daily exercise is key, especially with amplified pain. Daily exercise is key with arthritis. So exercise is pretty great. It helps your immune system function better. It helps your nervous system work the way it's supposed to. And it can actually regulate mood. And you release actually happier hormones when you exercise. So exercise does a lot of things. And if exercise feels very daunting in the traditional sense, then we certainly bring in physical therapy or really just focusing on some daily consistent activity to start. It's really about doing something every day and working to be consistent, even if it's not perfect or it's not as much as you want to be doing. If there is pain to touch or pressure, we utilize something called desensitization. Desensitization means if it hurts to touch it, then you should touch it, rub it, pat it, massage it. If you've ever hit your funny bone that hurts really bad, you might instinctively rub it. When you rub it, you're forcing those pain signals not to feel pain anymore, to feel the rubbing and feeling the pressure instead. If you've ever had a scar after an injury or a surgery, it can get itchy. You rub it till that goes away. That's desensitization. So it's really retraining those nerves directly. And I certainly have some kids with arthritis who don't even, technically, I don't say they have amplified pain syndrome, but even with an arthritis flare, they have a lot more sensitivity sometimes just to touch. So their nerves have just gone a little overboard in that flare. So even in the flare, I do desensitization to their skin. So there's no danger in doing that. So doing some rubbing, so touch or ice or things like that, that works to help calm those nerves on the outside a little faster to keep them from going haywire. And then counseling and stress management is key, which we'll get into more. Decreasing that pain decision making. Requiring school attendance and functional activities is key. And most patients with chronic pain conditions actually get better outpatient, just kind of doing that philosophy of physical activity, desensitization, counseling, and stress management. A lot of my teenagers, they just need permission to move despite their pain. So a lot of them have just been told like, oh, don't do that. We don't know what this is. This could be dangerous. But once they learn it's not dangerous and you give them permission to move, some of them are fine moving through that. They know what that means, especially kids who are used to sports or exercise or things like that. And just talking about pain may not always be dangerous. And really working with your team to identify that, but also making sure that you are working with your team to make sure that the exercises for your child is appropriate, considering their arthritis history, joint stability, if they have hypermobility, or any injury history. You want to make sure those things are taken into account. So exercise is still good for everybody, but some people may need certain plans tailored to them based on their previous physical history. So specifically, and I've mentioned some of this already, when you have amplified pain, if it hurts to do something, that's what you should do. That is a super hard message to hear, and it is all easier said than done, so I recognize that. But that's the idea of it. It may not always be perfect, but moving in that direction. Function comes back before pain goes away, or fatigue goes away, or other symptoms. So function is walking a long time, playing your sports, being at school. Function comes back before pain can leave. Super unfair. Ideally, pain and fatigue would go away, and then you would do all the things that you want to do. And sadly, that's not always how it works. Sometimes you have to do normal things to teach your nervous system what normal is in order to give your brain permission to release that pain and let it go. We've talked a lot, I keep bringing it up, minimizing pain and fatigue decision making. And I would go back to that. For example, if you're gonna go to the store, set a goal of we're gonna shop for 20 minutes. And so just work on setting goals if you're finding there are issues with that because of pain itself. And so we're gonna go for 20 minutes. And if at 15 minutes, your child really wants to not do that anymore, get to 20, just get to 20. That was the goal, that's what you're gonna do. You're not gonna let the pain make the decision to stop at 15, because that just empowers the pain to stick. If you get to 20 minutes, you're like, I feel pretty good, I could go longer. Don't do that either, because that's another health decision maker. It's better to try to stick to the goal and the plan, because then your brain doesn't have to check in based on how you feel. It knows you're just going to do it no matter what, and it's not based on how you feel that day. So the more you can kind of plan things out in advance or how the day is going to look so that symptoms aren't the driving force, that's really helpful. As you do more of these things, especially if you've been kind of immobile for a while or having fear of pushing through pain, sometimes when you first start to do these activities, symptoms can worsen before they get better. It kind of means you're doing a good job and you're scaring your nervous system a little bit. It's not a reason to stop. It's not fun. It's not easy, but there is a light at the end of the tunnel. Oops. So when I see patients with chronic pain conditions, I typically prescribe physical therapy to work on a home exercise plan with patients and develop a plan that's safe for them and joint protective, but one that also gets their heart rate up, sweaty, out of breath. My goal is 45 minutes a day of exercise, 30 minutes of full body strengthening, 15 minutes of cardio. That's the ideal. Do not let perfection be the enemy of progress. So just do something, daily consistent activity, even if it's just stretches that day or going for a walk. We already talked about adding in the desensitization. For desens to work, you have to do it 5 or 6 times a day, and it's 5 to 10 minutes at a time. If you do like 2 minutes, it's enough to make your nerves really mad at you, but not reset those processes. And then I'm going to launch into these next parts. So reminders, pain increases stress, stress increases pain. That sympathetic fight or flight nervous system is then turned on all the time, which releases a huge stress into your body and specific stress hormones like cortisol and catecholamines. And then pain alone is emotionally stressful, which can increase pain itself. Exercise helps regulate stress and pain, but you cannot exercise pain away by itself. You have to do the stress management piece. So I talk to almost all of my patients about counseling. I think everyone in this world should see a counselor at some point in their life. I think sometimes it's good to talk to someone you don't eat dinner with at night. And some of my patients are like, well, I talk to my parents all the time, and that's really great, but sometimes it's good, and I'm glad they do, and sometimes they don't. But it's also good to talk to somebody who has training to really help troubleshoot and to explore some of these ideas and to really bring about a plan in a different way than we can do at home. And so really normalizing counseling and that all humans have stress and that it's okay to talk to someone. And if it feels weird at first, just have an open mind, and I think you'll surprise yourself. Most of our patients don't need counseling forever, but it can certainly be very helpful when you're dealing with pain. But also in my kids who even don't have pain, who have chronic diseases like arthritis or lupus, like that can be life-altering, and especially for some kids. And sometimes talking to somebody about the stress of the diagnosis, having to do things that are different from your friends, worrying about what people think, all of those types of things. And then there's just regular stuff to talk about, like perfectionism and grades, peers, and our kids right now are generally having a tough time. And so anxiety and depression is at an all-time high in the pediatric population as a whole. And then in addition to counseling, just general stress management strategies is really important. So we refer to this as self-regulation, which are relaxation strategies. So that can be as simple as breathing, paying attention, and slowing your breath for 2 minutes 3 times a day. There are all sorts of apps for this now because everyone has been very stressed out the last few years. And so you've probably seen commercials for like the Calm app and things like that. So this is a muscle you have to practice. And some kids at first are like, I don't like doing this stuff. This feels weird. I don't feel anything. You have to practice it. You have to dedicate time to it. The more you do it, your body will start to notice it and start to relax your body, decrease your pain. And it's really huge if you have GI symptoms to do that relaxation piece. So there's certainly relaxed breathing, mindfulness, imagery, and I think these are definitely things to explore more at the next roundtable too. Unfortunately, sleep, Netflix, video games, not true relaxation. That's usually what my teens tell me they do. That is great distraction or escape, which is very helpful, and I'm not against it. but to find true relaxation as you're really paying attention to what you're doing in the moment. I think most importantly, and what I hear, like, what do you do as a parent when you have a child who's really struggling with their condition or chronic pain? Number one is validating, listening, letting them know that you don't have to see these symptoms to believe them and to know that it's real and to know that they know that. Really work with your child even at early ages to start communicating with their doctor about their experience. Only they can feel their body. When I'm in a patient room, I mostly ask questions of my kids and ask parents to fill in the blanks later. I think it's really important that our kids learn to advocate for themselves early and start to explain what their experience is. As a parent, neutral responses to pain is really important, meaning if pain is high, don't panic. If you panic, they will panic. They will see your response, which can escalate their response, or it can dampen their response. So especially if we know this is chronic pain condition, we know what this is, we know what to do, we can work through this together. Or we should figure out, I wonder if this is all inflammatory, or if this is your nerves overreacting, or maybe it's both. We'll figure that out too. Minimizing discussion of pain. So it can be tempting to check in a lot, like, how's your pain today? Where's your pain at? The more you bring it up and talk about it, the more you think about it, and the worse it can actually get. It's kind of that idea, if you're like, am I starting to feel a little sick? I think I'm starting to feel a little sick. And you start to feel those symptoms get bigger. So your brain is really powerful. Talking to your child about their body might be noisy. And sometimes it's important to listen to the noise, and sometimes it's okay to ignore the noise. And working with your team to figure out when it's okay to ignore the noise and to move through it. Most of all, helping your child build up life. So I think especially over the last few years, kids have become more isolated. They're doing a lot more of their peer relationships through video games, but helping them explore life again and finding things that they enjoy, hobbies they might have, building friendships and relationships. The more you build up life, the less room there is for pain, and you can actually push pain out of the way because there's not room for it. So just know we do not expect you to know how to do a joint exam at home to figure these things out. Give yourself some grace in the process. It won't always be easy, and it's not always right, and that's okay. And as I said, sometimes active arthritis, it's not even obvious to the rheumatologist, and so figuring that out. Don't be too hard on yourself. If you're having your child push through the day with pain, and you go to the zoo for 8 hours, and you come home and realize, oh, maybe there is a swollen joint, it's okay. They're probably not doing any damage in the short term. Obviously, you don't want that to persist long term. But that function and that building up of life, I would say, is more important than if there's a small, short miss in active disease. So certainly we want to get that taken care of, but having them have normal experiences is so critical. Also, you can validate your child to do this functional normal activity and really teaching your kids that they can have multiple experiences all at the same time. So it's okay to feel worried or nervous, but also to feel brave at the same time. So we have a mantra at our house, we can do hard things. Or the other day, I told my child, you can be anxious and brave at the same time, and he's 5, and he's like, no, I can't. And so we continue that conversation too, because you can hold multiple things and make space for multiple things. So other considerations, just moving through this process and this journey that we have found to be really important is just getting involved with mentorship groups for both you and your child. There are obviously really stellar opportunities through the Arthritis Foundation and Connect groups. And then some, I know our hospital has parent support groups that we've developed as well. So checking with your local rheumatologist too to see if they have any additional groups if needed. And encouraging your kids to meet other kids going through similar things like you're doing just by being here. So kudos to you for taking that step to come to do this and build that community. I think that's really critical for you as parents, but also for your children. We know our patients really love camp. And then working with your rheumatologist on school support, 504 plans, things like that. Make sure you have all the support you need to minimize stress as much as possible. And I would say the other thing I think is really important is working on scripts with your kids. And you can work with your social worker or a counselor or your doctor about how can they talk about their pain or their disease. If pain is not improving, you might explore pain centers with multidisciplinary teams or more intensive treatment programs. There's a comprehensive list of all those programs at childpain.org. And many pediatric rheumatologists have a lot of experience referring to these programs. So if you feel that would ever fit the bill, you can ask them about it. We're going to talk all about other modes of pain management possibilities at the next session. So join me at the round table if you have questions. And we've really talked through all this, but not all pain is dangerous. All pain is real. All pain requires a biopsychosocial approach. And sometimes treating pain requires the opposite of what you expect. And all pain responds to some degree of physical activity and stress management. So more resources. And with that, I think any questions? Thanks. Okay, we have a few questions. Let's see, if your child feels pain bigger than typical, such as a large hurt response to a simple stubbed toe, is there anything to do to help them? Yes, so in those moments, validating, I know this hurts, but also recognizing as a parent that probably is bigger than it needs to be. So specifically something like a large stubbed toe, I would desensitize that right in the moment. And so rubbing it out. Sometimes distraction can be really helpful in the moment as well. A lot of kids are able to be redirected to something different or something that they enjoy. And then sometimes, even though it feels very counterintuitive in the moment, is to use that body part and to start moving. And that can actually start to reset it pretty quickly. Have you found any psychologic effects with patients dealing with ongoing pain? How do you advise these patients with both psychological and physical pain? Yes, so we definitely know that chronic pain alone can increase risk of anxiety and depression and just overall mood disorders. So as I mentioned before, we talk a lot about counseling with our patients and then those relaxation strategies. And some patients with anxiety and depression, if it is severe enough or not improving with talk therapy, some kids do need medications for anxiety or depression. And so sometimes that is something that can be really helpful to help kind of get them over the hump. Question, how are insurance companies reacting to this science? Are they supportive? Do they challenge it? So as you know, insurance is a challenge, always. It's actually not been that bad for our pain management group, though, I will say. So I think we have a pretty good approach to it. We get patients to our pain clinic from all over the country. There are pain clinics to some degree, most everywhere, but like I said, we also have a multidisciplinary, intensive, prolonged pain rehab program that's 4 to 6 weeks long, where they do 5 to 6 hours a day of physical and occupational therapy. They get counseling several times a week. They learn relaxation strategies through art, music, yoga, etc. So it's a really involved, intensive approach. That's where our insurance comes into play for us for the most part. But then we do have to get insurance approved oftentimes for families just coming from afar to see us in pain clinic. As a whole, it goes pretty well. And we've had pretty good luck with it. And so I think they have been receptive, and we do a lot of educating. So far, so good, knock on wood. How do you help families determine if it's time to explore a pain clinic program versus an outpatient PT, OT, and counseling combo? I think most everybody should start with that outpatient PT, OT counseling. We typically do an intensive pain program if they're failing those outpatient therapies and not seeing improvement, especially in their function and ability. There are some kids, though, especially if they're, wheelchair bound, or I've had kids, their pain is severe enough they're like not able to bathe themselves, or if it's really impacting activities of daily living and function, not going to school anymore because of pain. Some of those kids would benefit from probably fast tracking to a multidisciplinary clinic. But for the most part, if you're just starting to see some of the emerging signs of pain, doing that kind of outpatient piece can actually go a long way. And most patients do get better that way. Trying to understand how a child with high pain tolerance has these huge outbursts with small incidents, stubbing toe, bumping into something. I hear that a lot. The nervous system's super interesting, and I hear a lot of kids who have long history of high pain tolerance, and then it goes overboard. And then I have other kids who, even though they have amplified pain in other areas, other parts of their body feel almost no pain. So pain is just really this interesting continuum. I would say with amplified pain too, it is consistently inconsistent. So it doesn't always make sense. It can ebb and flow throughout the day. Every hour can look different. Every day can look different. I think it's hard to know what to expect, which increases the stress of it. And so it's not unusual to see things that don't make sense, and I think that's a hallmark of the condition. Is nociceplastic pain the same or similar to oversensitivity to discomfort? Is amplified pain response ill-fitting clothes, scratchy textures, etc.? So I'd say, all of that is somewhat overlapping. So nociceplastic pain is the same in my mind as amplified pain and centralized pain. So those are all just overlapping terms. I think we're just always struggling to figure out how to best describe this and define it. And I think that's hard because there's so many layers to how pain works in the body. So you can have this like pain to touch or allodynia. So I do have patients where clothing bothers them, sheets and blankets bother them, where a waistband bothers them. So basically, even just clothing is painful. But then that might be different from somebody who has sensory processing disorder, maybe related to autism, where it's just like textures bother them or things feel weird or they just don't like that. And so I do have a fair number of patients who might also have autism, spectrum disorder, or sensory processing issues, which is seeming to show that could also be somewhat of a setup, like the nervous system doesn't quite process the way it's supposed to, and could open the door more easily to something like a chronic pain condition. So I'm often with patients trying to discern, is this just a texture issue, or you work on sensory issues versus pain itself? And so there's certainly overlap with all of those conditions. To manage pain successfully, do patients need to see rheumatology, PT, OT, and counseling? So some kids manage pain successfully just by hearing the message that it's okay to do normal kid stuff. And honestly, that's all some kids need. Like, you can go do your sport or your activity, and for some kids, that's enough. I have plenty of patients that work just closely with their pediatricians to kind of work through this process. You don't have to see PT. I think there are some kids that know how to exercise, but sometimes you get to a place where, in some ways, your body has betrayed you, and you just lose a lot of strength and endurance over time, and a lot of confidence is part of the issue sometimes. And so seeing physical therapy, I think, can give your kids a lot more confidence in their ability to do more and to be able to move forward with their exercise plan. Says, if there are no pain clinics in my area, can patients come from out of state to see you? If so, is coordinated care between multiple practitioners done in that visit? So as I said, we do get kids from all over the country. So there are a handful of intensive pain rehab programs across the country. And so I put in the slide deck, childpain.org has a list of those. And then there are a lot of different multidisciplinary pain clinics that are pretty much in every state, but not everyone has an intensive approach. And every place is a little bit different too, in how they might approach it. If you come to see us, typically, you just, within our clinic visit, it's multidisciplinary. So you see a medical provider such as myself, you would see a psychologist, you would see a social worker, you would get some teaching from nursing, you would have a social worker meet with you. So a lot of the pain clinics have multidisciplinary appointments in that nature. One more. Oh, we're done. Okay. I'm getting the, okay. So with that, I hope to see you guys, if you're interested, to talk more about some of these things that we didn't get to expand on, as far as ideas for complementary pieces to treating chronic pain, or if you have questions about that or things that we didn't get to touch on. I will be available at the roundtable at 10:45. So I hope to see some of you there. I appreciate your attention and the opportunity to speak with you today. Thank you.
Good morning, and thank you, Dr. Hoffart, for a wonderful and very inspirational educational talk. As you know, we had a lot of questions. I think we could have spent another 2 hours in here. So please go to the round table in the JA Cafe, and Dr. Hoffart will be there, and she can answer any questions she wasn't able to get to just now. So this morning, I have the pleasure and the honor to present the Arthritis Foundation's Young Adult Leadership Award to Dangerou. Andrew's journey is really fairly new. He was diagnosed in June of 2021 with arthritis. Instead of allowing this news to define him, Andrew transformed it into a catalyst for change, not only in his life, but also in the lives of others. He has wholeheartedly embraced the arthritis community, serving as a guiding light for those navigating similar challenges. Through his role as a junior ambassador for the Arthritis Foundation, Andrew has worked tirelessly to raise awareness and to advocate for improved treatments. Andrew has also expanded his reach and his impact in other remarkable ways. His self-published children's book, Archie Airplane Has Arthritis, stands as a testament to his creativity and his empathy, and serves as a reminder to countless children that they are not alone in this journey. He has also written for esteemed publications such as the Spondylitis Plus magazine and for the Spondylitis Association of America's website, providing invaluable insights and support to individuals facing chronic illness. Additionally, his presence at major events, including the Walk to Cure Arthritis in Arizona, has allowed him to inspire and to educate others on a grand scale. Andrew's genuine warmth, compassion, and ability to connect with people set him apart. His heartfelt speeches, delivered to thousands of attendees at renowned sporting events, have not only raised awareness of arthritis, but have also touched the hearts of many, many others. Congratulations, Andrew, on this very well-deserved award. Your dedication and passion inspire us all, reminding us of the power of empathy, kindness, and the unwavering spirit to make a difference. Please join me in congratulating Andrew and wishing him well as he heads off to college.